go to the restaurant, and you got a waitress that is probably my age or older, and you're like, I asked for non-sweet tea, and this is sweetened tea, and this lady's looking at you like this. All right, I'm 53, I'm going through menopause, I'm happy to serve you. What else can I do for you? Because menopause makes you feel like that. Menopause does make you feel a little cranky on days, more days than you would like to admit. But ultimately they say, I don't know, I've been going through menopause for about 5, almost 6 years now, and ultimately they say it'll go away. I mean, it didn't seem to be leaving anytime soon, you know? So when your patients come in, and I don't know, from an Air Force standpoint, what type of patients you guys see, if you see only active duty, but I know for both, okay, so I know for Army as well, you see kids, you're seeing active duty, you're seeing their dependents, you're seeing their parents if they're a dependent. So you'll see a whole gamut of ranges for patients and their ages. So you might be seeing patients that are coming into you certainly with signs and symptoms of menopause. And it's important that we not only think about menopause as a diagnosis, but of course think about the differentials in these patients. Because if you say every 50-year-old that comes in, they must be in menopause because they're having hot flashes, or night sweats, or maybe weight loss, not likely, more weight gain, then you're going to miss the differentials in some of these patients. You're going to miss something like hyperthyroid or a cancer that these patients have. So yes, keep this on your primary diagnosis as someone that comes in and having multitude of symptoms, but also remember we have to treat that differential. So we're going to talk about menopause today. We're going to talk about osteoporosis as well. And then I will start the vulvar and vaginal lecture that was asked to, so that way I guess next week you won't have as much to do. Does that sound right? Are we still on with that plan?
Yes.
All right, sounds good. Okay, our ELOs, we do a little check on line. 29-year-old female comes in, gets painful menstrual cycles, painful intercourse over the last year. Seen about a year ago, prescribed ibuprofen and a combined oral contraceptive. And minimal improvement despite taking those medications. First of all, I would say, why has it been a year since you're seeing, right? Come back sooner than that. Transvaginal ultrasound, unremarkable. What do you think the next thing for us to do for this patient? Should we, so she's not in GnRH, okay, do you want to put her on GnRH with add-back therapy for this patient? It's a consideration, but the problem is we don't really know what's going on, right? We don't really have a diagnosis. So remember those medications, GnRH, are not without significant side effects. So it might not be something you want to just throw on a patient to just see. Let's see how this does for you. Could we just change to a different NSAID? No, because we talked about NSAIDs, right? We said there's none that's one better than the other. There's a superiority. So if you already have an anti-inflammatory, then probably changing isn't going to help. Replace her oral contraceptives with an intrauterine device. We could. What are we doing if we're doing that? How do we think that that's going to help? She's already on a combined oral contraceptive. It gets you estrogen and progesterone. So if you're going to change a progesterone for a progesterone, probably not going to help. Probably not going to help. You did the low progesterone IUD at the beginning. I also wouldn't go back and change her to combined oral contraceptive because you've already tried the contraceptive and it's not really beneficial. Should we refer?
Yes.
Yeah. We should probably refer. We can't fix everybody. That's why people specialize. That's why they get paid 4 times as much money as we're going to get paid. Right? Because we, those are the patients that, hey, I've done what I've done. Ultrasound is fine. I've tried this medication. She's still not better. Please help. Okay? Hydrocodone. Right? We always give patients opiates for pain. Not in the opiate epidemic time period. Right? So we want to really avoid. Very seldom should you guys prescribe it. So now, for those of you that are interested in going to orthopedics, God, orthopedics loves opiates. It's nothing for them to send someone home with 300 Percocet, legit.
Oh, yeah.
And they will come, those patients will come and see you, and you're like, okay, you're whatever, post-op, tib surgery or something. What are you getting for pain? Oh man, they gave me 3 bottles of this Percocet. Give those to me. We gotta be careful because those patients will get easily addicted. And if you talk to young adolescents that have had some sort of surgery and they were put on opiates or read any literature about that, those patients will say, that's what did it. I had, it used to be tonsils and we gave them Tylenol or codeine and they became addicted right after that to opiates. So be really careful with the opiates, be careful certainly with prescribing them. If you have patients that are getting bottles, I'm talk to your patients about that as well. All right, so let's go through a little bit of terminology when we talk about menopause and the time period surrounding menopause. Menopause is defined as that time where we've ended all of our menstrual cycles. It is diagnosed specifically after someone has not had any menstrual bleeding for 12 months. So 12 months of no menstrual cycle. And it really occurs due to loss of normal ovarian follicular function. Okay, so we call that follicular atresia. The average age of menopause is going to be about 51 and a half for people in the United States. We have a menopausal transition and a perimenopausal period. Both of those begin about 4 to 7 years before menopause. Menopausal transition is going to stop in that first day of that last menstrual period. That last menstrual period is complete. And perimenopausal period stops when menopause begins. So perimenopause takes you that extra year when the patient doesn't have their menstrual cycle. So they started about the same time, but just one lasts a little bit longer. Average age for patients who start either menopause transition or the near perimenopause period is about 47. And this tends to be the most symptomatic time for patients. When patients come in at that 47-year mark, they're used to their ovaries functioning completely fine. They're used to enough circulating estrogen, they don't have a lot of symptoms. So they're coming in because they're like, wait a minute, what's going on? I'm only 47, I feel like I'm too early for menopause. And most people don't know about this perimenopausal menopausal transition state. So why am I feeling so crappy? Why am I having these hot flashes? Why all of a sudden can't I lose weight? Why am I not sleeping well? Why am I not thinking clearly? This is what's going to bring these patients in around the mid-40 time period. We have postmenopausal period, so after we have the final menstrual period at 12 months, okay, then we have the postmenopausal period. So from then on, patients are known as postmenopausal patients. And we can actually document that in our note a lot of times because sometimes it's related to whatever they're coming in for. Postmenopausal period, based on patients' lifespan now, can be up to 1/3 or 1/2 of a person's lifespan. So if someone went through menopause at 50, they may have another 50 years in them, right? I mean, what is the average age for women to live nowadays? 79 or something like that, 80 years old. So I think when I was in PA school, it was like 67 and a half. So it's insane, right? We've got a lot more older people living now than we do younger people. So they may spend a good portion of their life in that postmenopausal period. We have something called primary ovarian insufficiency. If you're reading a little bit older literature, it used to be called premature ovarian failure. And this is when these patients are less than 40 years old and they're coming in to see you about these hot flashes and these night sweats and this weight gain, but they're not even 40 years old. That is not menopause. Even if they come in and say, well, my mom went through menopause at 40 and my grandmother went through menopause at 40, that's not menopause. Something is causing their ovaries to fail earlier than what we expect. Think about things like chemo or radiation or medications these patients may be on. On labs, they typically have an elevated FSH, just like we'll see in menopause, but the ovaries and the follicles in the ovaries are designed to last longer than that. So if they're coming in before the age of 40 and they're having signs and symptoms associated with menopause, Don't think it's menopause. It's not menopause. It's your job to figure out what it is, or at least try to figure out what it is by doing a bunch of biopsy excisions and that. There's a lot of different causes, but we don't want to diagnose these patients as menopause, and then we're going to miss the actual underlying cause. It's not a natural response. This is what it looks like on the timeline. So we have our reproductive time period, okay? And our very early reproductive time period, we know our menstrual cycles are variable. And then they kind of even out when people have more regular menstrual cycles for the majority of their reproductive age. And then we talk about 4 to 7 years before menopause, we start to have that menopausal transition, or that perimenopausal period. We have menopause. After menopause, we have an early postmenopausal period and a late postmenopausal period. So when we think about perimenopausal and early postmenopause, that's going to be the most symptomatic time for these patients, and that's where they're going to come and see you because of the symptoms that they're having, if their symptoms are severe enough. And then after that, we just have that postmenopausal, and then patients are known as postmenopausal. So we've got physiologic changes that occur. We've got changes in the menstrual cycle. Oftentimes, the menstrual cycle time period shortens. Okay? We have a lot more variation in our length, so it can be short. We have variation between the menstrual cycles. They may go a couple months without having one, and they think, okay, this is it. This is the end. I'm having all these hot flashes, and I have to have a cycle, and then next you know they have a cycle for another 2 or 3 months. Okay? So we got to go that entire 12 months without a menstrual cycle for it to be called menopause. And these patients, because the most common cause of their irregularities is they're having both ovulatory and non-ovulatory cycles. The issue with that is they can have the surprise pregnancy, right? Anybody have they're 30 years old and they have a brother or sister that's like 5? Okay, that's because your parents didn't think they could get pregnant. Oh no, I can't get pregnant. I'm going through that menopause stage, right? But they're having ovulatory, non-ovulatory cycles, and so we want to counsel our patients about that. Yes, you are transitioning to menopause. You're not there yet. There's still a likelihood you get pregnant. You can get pregnant. So if you don't want that, let's put you on some sort of contraceptive, or let's talk about contraceptive methods. Good thing is you can tell them there's no reported pregnancies after the age of 55. Right? So you're good. If you're 56, you should be good. But below that, they can get pregnant. I had a patient maybe about 2 months ago that was 54, and she was pregnant, spontaneously pregnant. I was just like, my heart went out to her so bad. 54, holy moly. That is a lot on the body to go through. Man, that's a lot on the mind. So as that menopausal period, that menopausal transition progresses, again, we're going to have more and more skips in menstrual cycles. A lot of times they'll go 2 or 3 months in between your menstrual cycles as well. Labs, we're going to have a high FSH, high LH, okay, lower than estrogen progesterone. Remember, the ovaries are not working. They're not picking up estrogen progesterone. But the pituitary doesn't know that. The pituitary is going to bombard the ovaries, which gives us that high FSH. Postmenopausal period, we're looking at FSH is greater than 40. Normally they're about 5 to 20. There are other changes that we're going to see as associated with menopause besides menstrual cycle changes. Cardiovascular disease, so cardiovascular disease, leading cause of death in women over the age of 50. Estrogen is cardioprotective to some degree, especially in that early postmenopausal, early menopausal period. But by the time a patient is 70, estrogen is no longer cardioprotective. So for the first few years, we're going to get some protection from the little bit of estrogen that's being released, or if they're on some sort of estrogen progesterone control. Okay. Weight gain is definitely a thing in the perimenopausal and postmenopausal period. A lot of women will gain weight around their abdomen, around their hips, and regardless of how much exercise they do, they still tend to gain weight. And again, a lot of times they're going to come in to see you about that weight gain and what can we do about that. We've got dermatologic changes, so skin change, where you typically get hyperpigmentation, call them age spots. And that's because the tissue just becomes thinner, it's less elastic, it doesn't have as much blood supply because we don't have that circulating estrogen. Okay? And the tissue itself isn't as resilient, so patients will get bruising a lot easier, they'll be cuts a lot easier. So we want to talk to our patients about being careful about teeth. We have dental changes that can occur. There's less saliva in the mouth. We have increase in bone loss. Okay? That increases the risk of dental caries or dental infections as they get older, even with appropriate dental hygiene. Okay? And then CNS changes, sleep dysfunction. These patients can have sleep-ordered breathing or called sleep apnea. Typically, they have poor sleep quality in general, especially if they're having hot flashes, because they oftentimes occur at night. They have decrease in cognitive function. It's the whole thing of, where to leave my key? What was I opening the refrigerator? What was I looking for in this refrigerator? Stuff that you guys can probably relate to because most of the time you guys are sleep deprived during day one. And then ultimately, if you're not sleeping well, okay, and they're always tired, that can lead to depressive symptoms. Older females are 1.5 times more likely than males to have issues with depression and need treatment for those psychological issues. We've got changes in the breast. We have loss of breast density, and so the breast get more adipose tissue or more fatty tissue associated with it. We've got GU symptoms that can occur, and then skeletal as well. We've got loss of bone mass density because we have increased resorption, which leads these patients to a higher rate of osteoporosis as they get older. Most commonly, they have hip and vertebral fractures that are associated with that. Because FSH does play a role in menopausal symptoms, that is just mnemonic. Of course, I did not make this up, okay, but it's called fistule. That tries to remind you of what the patient's signs and symptoms could be that are associated with menopause. Flashes, flushes, forgetfulness, okay, they're sad, got skin changes, skeletal changes, sweats, an increased risk of stroke, okay, sexual dysfunction, decreased libido, headaches and heart disease, insomnia, urinary symptoms. All of those things are associated with menopause. The picture here, this represents a classic person with VMS, vasomotor symptoms. Vasomotor symptoms, that's what we call hot flashes. That's a medical term for hot flashes. And really, it's a thermoregulatory dysfunction at the level all the way up in the brain at the hypothalamus. And it's caused specifically by estrogen withdrawal from the patient. Oftentimes, these patients will have several episodes of these hot flashes or hot flushes that occur throughout the day and throughout the night. They have increased temperature in their skin, not increased core temperature like you might see with a fever. And they're really just trying to offload that heat. I know lately, that's my feet. And every time I go to bed, I'm like, my feet are on fire. Like, I cannot get rid of that heat. Okay? But when I went through started menopause, every hour on the hour, 150, 250, 350, 450, all day, all night, hot flashes. I thought I was going to die. I could not get rid of these hot flashes. And that was 3 years of every day, all night. Because I don't want to take hormone replacement. Now, there's a lot of literature on the hormone replacement, and really the newest literature of the last couple of years says, estrogen probably gets a bad rap. People really need estrogen in their body. And so it's still something that we promote for a lot of people, but hot flashes are, you wouldn't think that they're bad, but they are terrible. When my dad had to have his he had prostate cancer, so he had to go on treatment, and there's a little bit of estrogen, he was having hot flashes, and he would be like, now I know what you're talking about. I see that. But the other issue is these hot flashes can last for a long time. 15 or 20 years. So my recommendation to you, when you're talking to your patients about these hot flashes, and they say, well, how long will this last? Don't tell them. Don't tell them 15 or 20 years. I wouldn't do that. I'd say, well, it really just depends on the person. That's the word thing I would say. I would not tell them 15 or 20 years because they may not leave that office, and you may not leave that office a lot of it. But most of the time when they do occur, it's a couple of minutes, they have increase in skin temperature, all the covers come off, and then once they're done, all the covers come back on. So it's just a process that they take. Usually a couple years before menopause, before that final menstrual period, and again, they can last for 7 years after that final menstrual period. GU symptoms of menopause. So we call that, we used to call it atrophic vaginitis, but now it's called the genital syndrome of menopause. And this is the most common cause of vaginal irritation in these menopausal patients and postmenopausal patients, affecting up to about 40% of patients as they're starting to transition into menopause, and they'll continue through in that postmenopausal state. And that's because the vagina is very estrogen sensitive tissue. We have that lack of estrogen as we go through menopausal time period. So these patients oftentimes will come in with vulvar irritation, or they might have a clear discharge, and they may have complained of vaginal dryness or irritation. Oftentimes urinary symptoms, but the urinalysis is negative. Urine culture that was sent is negative. And they may complain of dyspareunia because that vaginal tissue is really sensitive and they're not getting any lubrication. So that may be their presenting sign and symptom. And if they come to you because they're not able to have intercourse like they're used to be able to have, and what can you help them, how can you help them with that? And unlike vasomotor symptoms that typically kind of decrease over time, these genitourinary symptoms tend to persist without retirement postmenopausal, but they can be treated. So we're going to diagnose this by patient signs and symptoms. You can do a physical exam. You can see that the vaginal tissue itself will look more pale. And you might see excoriations from itching. If pap smear, if you see some sort of cervical cytology, if you see something called parabasal cells, that is diagnostic for atrophic vaginitis in these patients. But well, again, we can treat this. We can give patients topical estrogen, and that helps significantly. You can use just lubricants, petroleum jelly, KY jelly. We can talk to our patients about that. And then second line would be that topical estrogen. Usually they can just do it a couple times a day, or once a day for a couple weeks, and then after that, sometimes they only use it a couple times a week. When we think about postmenopausal patients, and we think about estrogen versus estrogen and progesterone versus progesterone alone, I want you to just categorize uterus or no uterus. Okay? Now, for topical estrogen, and you can do topical, we talk about topical estrogen, we talk about the intravaginal ring. They do not need to have progesterone with that for up to 1 year. So you could use unopposed topical for up to a year. You cannot use oral estrogen without progesterone if they have a uterus. With topical, you can for up to a year. So how do we know our patient is going? Yes.
So after the year is up, let's see if we can talk about do you orally supplement their progesterone, or is there a balance between that's progesterone and estrogen?
So you could, okay, you could come off the estrogen, and usually they'll recommend coming off of it for a few months, and then you can go back on it. You can do that, and then just supplement that with like the lubrication. Okay. Ideally, you'll keep the patients on the estrogen the least amount of time possible, but because this can persist forever, you can give them breaks with the estrogen, or have them substitute that with the lubrication. Once they use that estrogen for a year, typically they can just switch to the other lubrication methods, and they do pretty well with that. But ultimately, if you have to put them back on, you can. You just want to give them a break. Okay? And if you try them on the estrogen, it works really well, then switch over to lubricant, it doesn't work, then you can add an oral progesterone to that. Just for you, so you can balance it out.
Would you use something like the POP then?
So POPs are still really difficult. So they may even consider something like an IUD, but ultimately, if they choose to do a POP, it's just really good education for the patient. They can still do the injection. So there are other options, but you can still do the oral contraceptive, with the progesterone and the estrogen if that's what they want. So there are other options. I wouldn't say definitely no to the POP. It's just about patient education if that was what's prescribed. Sometimes they'll do more cyclic therapy, and they'll have them go on it for like 10 days. They can still do the topical estrogen for the whole month, or for the everyday, but then they'll add cyclic progesterone, like hydroxyprogesterone acetate orally, and that will give them that progesterone that they need. So how do we diagnose menopause? We're going to do that year of no menstrual cycle, right? So we're going to start from the beginning, and when was it your last day of your menstrual cycle? Did you have any bleeding since then? And if they have not, then we will typically go for that year. Okay, so look at their menstrual history, look at their signs and symptoms that's associated with that as well. Do they have vaginal irritation? Do they have a fistule? And then if they haven't had a pap smear or cervical cytology, this should be the time to do that. Make sure that we have no other reason for them to be having lack of menstrual cycle or these other signs and symptoms. If someone's under the age of 40, again, we're not going to diagnose them with menopause or menopausal transition. We've got to initiate an evaluation for primary ovarian insufficiency. Why are they having secondary amenorrhea? Why are they not having a menstrual cycle when they should have a menstrual cycle? So 37-year-old patients, they should be having normal menstrual cycles. They're in their normal reproductive age time period, so they should not have a disruption in the menstrual cycle. 40 to 45, we still consider that kind of maybe a problem, maybe not. Certainly, we can say that's probably an early menopause time period, but again, these patients may need a little bit of a workup because we still think about 47 is our time period. So if they're coming between 40 and 45 and they're having these signs and symptoms, there's nothing wrong with grabbing some labs on these patients. Think about your differential. Is it thyroid problems that's causing this? Get a TSH on them, get a prolactin, because intracranial problems can cause these signs and symptoms as well. FSH is typically going to be elevated, but probably not greater than 40 like we're going to see in that postmenopausal period. If they're coming in over the age of 45, they're having menopausal signs and symptoms, then they're probably in menopause. You don't need to do a bunch of labs on these patients over the age of 45 because that's probably where they're at. Now, certainly if they have a family history or they have a personal history of thyroid, then you can check that stuff. Right? But in general, we don't need labs to convince us that they're going through menopause at that time. Again, differential. These patients have ovulatory and ovulatory cycles. So let's think about pregnancy as our differential, because pregnancy can cause some most similar symptoms of hot flashes and weight gain. Okay? Hyper or hypoparathyroid. So hyperthyroid, how do these patients present? Anxiety, sweating, so same things that we think about, hot flashes that we think about with menopause. Okay, medications, so take a good look at their medications, making sure they're not on any medications that may be causing these signs and symptoms. And don't buy into the fact that these patients say, well, I've been on this medication for a long time. It can't be this medication. It can't be the medication. Medications, you can take them for a long time and then start to have side effects. So look at their medication. We want to try to make sure there's no evidence that these patients have some underlying malignancy or maybe a pheochromocytoma. Okay, so those pheochromocytoma are diagnosed twice ever. Those are super, super rare, and both of them were in phase 2. So that was a long time ago, y'all. So, so have that on your differential when someone's coming in with the signs and symptoms of, hot flashes and palpitations or sweating. We're going to manage these guys, and really we think about managing not menopause, but we manage the vasomotor symptoms associated with menopause. So we know we can manage our GU symptoms with some topical, but vasomotor symptoms, that's the reason why we're giving medications or hormonal therapy to these patients. Estrogen therapy, so unopposed estrogen we can use in patients that do not have a uterus, that have a hysterectomy. And then we're going to use estrogen, progesterone, or progesterone only therapy in patients that do have a uterus. So why do we not want to give estrogen to a patient that has uterus by itself? Because it's going to thicken the lining of the uterus. And it's going to increase the risk of endometrial cancer. And we don't want to do that. We don't want to put them at that risk. We're be really careful with that. Hormone therapy, again, we're really just replacing the patient's hormones by giving them estrogen or progesterone or estrogen alone. The ovaries aren't working like they once did, so now we're going to help the patient's body and help the patient along by providing them some hormone to help kind of even out this transition. Okay. But the main target of hormone therapy is going to be those vasomotor symptoms. If we can initiate hormone therapy early, we actually can decrease cardiovascular risk. We want to initiate it by the age of 60 or within 10 years of menopause. So someone who went through menopause at 47, by 57, we want to have them on some sort of hormone therapy to help with that cardiovascular risk. After 10 years, there doesn't seem to be any benefit. And then we do have, risks for patients that were put on hormone therapy. So we got to make sure that we do a good family history and a good personal history. Because hormone therapy, especially with estrogen, increases the risk of VTE, increase the risk of stroke, increase the risk of cardiovascular events, especially if they have a history or if we initiate hormone therapy later on. We increase risk of breast cancer in some of these patients, especially if we use EPT as estrogen progestin therapy. We use them beyond 3 to 5 years. The literature does show that if a patient can just be on estrogen therapy, there's actually no increased risk, okay? A lower risk, I should say. We have increase in bone density if we put patients on hormone therapy. Decrease in fractures, decrease in colorectal cancer. So we have some positives with estrogen therapy and we have some negatives. We have to kind of weed out the risk and the benefit ratio for every single one of our patients. This is not a blanket statement for all patients. Where here everybody gets the same dose and these same medications. You've got to do individualized therapy for these patients. According to American College of Gynecology, we should not be given hormone therapy, even though we have a decrease in cardiovascular risk if we start it early on. It's not a reason to start hormone therapy. So a person comes in and says, my dad and my mom both died at 50 years old from a massive MI. We're not going to say, oh, I'm going to put you on this hormone therapy because I want to reduce your risk. That's not the reason to do that. We're going to give it primarily for those vasomotor symptoms. Other things that we have to think about, oral estrogen. If we're going to provide, give patients oral estrogens, you want to think about some of the contraindications or complications. So if someone has hypertriglycerides, estrogen can actually increase their LDL. So you want to try to avoid that in those patients. If they have gallbladder disease or liver disease, it actually increases their risk of cholecystitis. Of course, if they have known clotting disorders or a known history of VTE, then you want to avoid estrogen in those patients. If someone has a history of migraine with aura, we typically recommend transdermal estrogen versus oral estrogen in those patients. All right, so patients come in, they're perimenopausal. They haven't quite hit menopause, they're still having some intermittent cycles. The recommendation is typically for these patients to put them on some sort of cyclic progesterone or estrogen, so not continuous. We're going to take it so many days out of the month. If they've got a hysterectomy, we'll typically do transdermal. Mild, depending on if their symptoms are mild to moderate or severe, will depend on the dose of the transdermal patch that you can recommend. Okay, if they have a uterus, not had a hysterectomy, then we typically going to put them on this cyclic dosing of progesterone. And we'll take it for a certain amount of days every single month. Most of the time with these treatments, either just the estrogen or estrogen progesterone, or just a progesterone, they're going to have some sort of withdrawal waiting. So you can talk to your patients about that and counsel them about bleeding after coming off the medication. If they're menopausal, and now the recommendation is a continuous estrogen or continuous estrogen progesterone or progesterone alone. We can still do a transdermal if they don't have a uterus. Right? We can still do progesterone. We usually will do a medroxyprogesterone acetate orally if they do have a uterus. Or you can do a combined oral contraceptive with a low dose estrogen. Usually we like to do about 20 micrograms for our estrogen for use of low dose contraceptive for that. Okay? Again, women that have a uterus, we do not want to give them unopposed estrogen. That's a quick way to be calling forwards, right? They're going to have a thickening of the endometrial stripe and they're going to end up with endometrial cancer, so be careful with that. There are some newer medications out there in the last couple of years. There's a SERM called, has estrogen and vasoxaphene associated with it, and that is called Duovay. And that not only treats the vasomotor symptoms, it also protects that endometrial lining by keeping it thin. And it doesn't tend to cause any changes in the breast tissue. So multiple things, and the last thing is it can help improve sleep. Some people will say it helps improve their depressive signs and symptoms, so it seems like kind of a cure-all medication. Most likely we don't have it in the military system, right? Because it's too good. Okay. So on the outside, you may be able to prescribe it, and if you are, most likely what? The insurance company doesn't pay for it. Okay. All right. Physolitants, okay, also called Deoza. Have y'all seen the commercial? I love that commercial. So there's a guy on the street, and he's going up to women, and they're older women. He's like, have you heard of VMS? Have you heard of VMS? And they're like, is that new Korean band? And they're like, no, vasomotor symptoms, vasomotor symptoms. Like, they have no idea. So apparently they're not me. Apparently they don't have menopausal symptoms. But anyway, Veoza, that's the commercial for Veoza. And in the military system, you can get Veoza. It's actually a non-hormone treatment for vasomotor symptoms, but it's a special order. But it is possible to do it. Okay? If their primary complaint is depression, you can put them on an SSRI. And guess what? SSRIs can also help with vasomotor symptoms. So you can kind of kill two birds with one stone. For hormone therapy, if you're going to put patients on there, excuse me, the standard recommendation is really try not to use it beyond 5 years. Now, that being said, we know vasomotor symptoms can last way longer than 5 years. So according to both the North American Menopause Society and the American College of Gynecology, they say, look, don't stop the medication based on age. Let's consider continuing these medications as long as the benefit outweighs the risk. And we can continue those medications for several years beyond that 60 or 65, but we want to start at the lowest dose possible. And of course, we want to take them off as soon as we can. Now, how do you take them off? Do you just suddenly stop the medication, the hormone therapy, or should you taper it down? And the recommendation in most literature is to taper down the hormone therapy. Because if we do that, they're a lot less likely to get rebound vasomotor symptoms. So we can continue it beyond that 60, continue it beyond 65, as long as the benefit outweighs the risk. And then we kind of want to put a mark on the wall. Let's do this for another 3 months and let's see where you're at with your symptoms, and let's see if we can then taper you off. And let's do it in 6 months and then taper you off. We don't want to say come back in 5 years from now. That's not really the ideal situation. We're not tapering them off as soon as possible. Before we prescribe hormone therapy, you've got to think about it. Is there a history of breast cancer? So we don't typically prescribe hormone therapy. Coronary artery disease, if they have a history of VTE or stroke. Active liver disease. If they have unexplained vaginal bleeding, we've got to figure out the vaginal bleeding. So there are some things that we have to think about before putting these patients on hormone therapy. If they're already at a higher risk of endometrial cancer, so PCOS. If they have a history of PCOS, that puts them at an increased risk for endometrial cancer. Why? Because they're having anovulatory cycles, right? So they already have that thing in endometrial cycle. So those patients, you want to be cautious about putting them on additional estrogen therapy. Again, non-hormonal treatments. There's nothing wrong with talking to your patient about non-hormonal treatments. You think about antidepressants, SSRI, SNRIs. Those can both treat vasomotor symptoms in addition to treating your depression. Gabapentin, that's what I've been taking for many years, and that's what saved my sanity, I guess, is gabapentin. I take gabapentin at night, and it helps significantly. So that's something that you can use. You know, gabapentin is really for anticonvulsant medication, right? It's for neuropathy as well, but also apparently is for vasomotor symptoms. Clonidine, what do we use clonidine typically for? Hypertension. We don't really use it much anymore, but it used to be, they use it all the time for hypertension emergency. So this comes in a transdermal patch, or comes in a pill, that they can use it. But remember, for clonidine, it is an antihypertensive. So you put these patients on, and there is a likelihood that they have a decrease in their blood pressure. So you got to remind them to get up slow on this medication because they can have some spinal hypertension. Pregabalin, also known as Lyrica. That is a non-hormonal treatment for vasomotor symptoms. And then we already talked about the some other things that are out there in the literature. Isoflavones like soybeans or chickpeas, black cohosh is one of the most common used alternative therapies that's available. And the problem is that some people say it works great, the literature says, I don't know if it works all that well. But I mean, if it works for that person, then there's nothing wrong with them taking it. There is topical over-the-counter progesterone that patients can use. Melatonin tends to help. And then we've got to talk to them not just about their menopausal symptoms, but remember these patients are getting older as well. So let's talk to them about other things. So if they can control their weight, oftentimes that will decrease their menopausal symptoms. If they control the amount of alcohol, so alcohol almost immediately is going to increase their vasomotor symptoms. If they have good blood pressure control, good control of their lipids as well, all of those can help decrease your vasomotor symptoms. And then of course smoking anybody's not good, and definitely in postmenopausal patients or perimenopausal is not good. In the military system, we have a little bit harder time providing consults for patients to do yoga and for them to do meditation. And so you may not be able to do that in the military system, but you can certainly recommend for these patients to do that. Yoga, meditation, acupuncture sometimes will work for these patients as well. Eat a healthy diet, exercise regularly. Like I never have a hot flash while I'm exercising, never. So I exercise, all day and all night, just so I don't have hot flash, right? Dress in layers. Keep cool. You have a way to be able to take one off while you're having those hot flashes, and then we know after the hot flash comes, typically comes a cold flash, so then you can put those layers back on. We recommend, like I had a individual AC unit installed in my bedroom 5 years ago. Because I was like, I can't tolerate this. The kids like, we're freezing to death. And I'm like, I don't. So in the bedroom it is like 63 at night, and then out in the rest of the house, I know it's awful. And I still all day on it. And then outside the rest of the house it's like 70. So, and then consume cold drinks instead of hot drinks. Certainly when you get hot drinks, then you tend to increase your TMA. We already talked about topical estrogen or topical moisturizers for these patients, and lubricants for these patients that are having discomfort with intercourse. Also, the recommendation for these patients is to have frequent intercourse. Usually the recommendation is a couple times a week, in that way that you maintain you're decreasing the amount of atrophy that you have in the vaginal tissue. Right? Just going without intercourse for 2 or 3 months, patients tend to have a significant amount of atrophy in the vagina and the vaginal opening, and they'll start having a lot of pain associated with that. The more pain they have, the less likely they are to have intercourse, right? And so if we can talk about these lubrication methods and having frequent intercourse earlier on in the perimenopausal period, then there are a lot less complications later on. Tobacco, alcohol, looking at their medications, you want to discontinue all those unhealthy habits that are associated with this. And then we're going to promote healthy, even vitamin D, vitamin C, okay? Regular activity. That's what we want to talk about this stuff. All right, so let's go ahead and take a break, and then we'll start our osteoporosis. So we have estrogen, we have those levels that are going to fall on that perimenopausal and that postmenopausal period. That has a regulatory effect on bone, or a regulatory effect for bone absorption loss. And as a result, so bone resorption is going to be accelerated, and usually is not going to be balanced by bone reformation. This accelerated loss is most commonly going to be in that early postmenopausal period, and it can result in osteopenia, and then ultimately these patients can get osteoporosis, so the thinning and the breaking of those bones. We have primary osteoporosis. That's usually going to be caused by age, caused by decreased estrogen. And then we have secondary osteoporosis, and that can be caused by other things like medications, like chronic medical conditions. Depending on that patient's age, these fractures can be associated with significant morbidity and mortality. You guys probably have learned in ortho that if you have an 80-year-old patient that falls and gets a hip fracture, they have a significant chance of dying because of that hip fracture. So you want to be able to identify osteopenia and then ultimately osteoporosis in these patients before they have some sort of fall. or they have what they call fragility fracture. Osteoporosis, you can define it by a DEXA scan, or if someone comes in and they have a fall from standing and they have a vertebral fracture or a foramen fracture or wrist fracture, that's called a fragility fracture, and that is indicative of them also having osteoporosis. Overall, we think of this as a secondary effect again of menopause or decrease in estrogen, but there are other things. So understand your risk factors for osteoporosis, and I think you guys have a pretty good lecture on this in ortho, but we have shattered family for our risk factors. So steroids, someone that's on chronic steroids, so maybe from asthma or COPD, and they can have increased risk for osteoporosis. Hyperthyroid, hypocalciuria, alcohol, tobacco. Or someone that's really thin, if they go through menopause early, that can increase their risk, okay, because they have decreasing amount of estrogen early on. And then even all the way down to family history. If someone has a family history of osteoporosis, and then we're apt to have osteoporosis as well. Initial evaluation for these patients is you're going to look for risk factors, right? So look for their medications, look at their family history. What about their own personal medical history, that increased risk? Do they have chronic thyroid problems? So that's going to place them at increased risk of developing osteoporosis. What if they have GI disorders, so they're not absorbing nutrients appropriately, that increases their risk. Okay. Do they have a history of fragility fracture already? They have walking outside and I fell and I broke my hip. That was considered fragility fracture. And then we want to look at labs as well. So labs, CBC, we usually do a lot of chemistry, which gives us phosphorus, we'll look at albumin on there. 25 OHD as part of our labs to look at a vitamin D level. We look at T-scores. We get that from a DEXA scan. Not we get that from a lab, so we get that from a Texas DEXA scan. So we've got initial labs that can be done. I just talked about. We've got some additional labs that might need to be done. Okay. If we have a personal history or patients are on medications that might need you to do additional labs, you want to be aware of some of those additional labs. You need to do 24-hour urine calcium may need to be done, especially for patients that have chronic celiac disease or chronic GI disorders where you're not avoiding. That's when you're going to add some of the additional labs in there. So you don't need to know all of these labs that are associated with this. And this is typically going to be kind of a case-by-case basis, except for your basic lab, your CBC, your chemistry, and your hydroxyvitamin D level. But really, we're going to use typically our T-score or our Z-score. So we look at those. For primary osteoporosis, we're usually going to talk about using that T-score. And most of the time, we tell our patients to know what their T-score is versus their Z-score. You guys remember the difference in that T-score and Z-score? The T-score compares it to like a 25-year-old person with bones, and the Z-score compares it to someone of their own age. But really, we recommend these patients kind of follow what their T-score is. Nowadays, I think when they do the DEXA scan, they'll give both the T-score and the Z-score on the result. But we think the Z-score is more of a secondary osteoporosis that we're looking at. So those shattered family risk factors, or they have some sort of medical history that would give them that secondary osteoporosis. The primary tool that we're going to use to evaluate for osteopenia or osteoporosis, that's going to be our DEXA, dual energy X-ray absorption scan. And then just take a couple of angles of the bones and really evaluate that. So we want to think about DEXA scan for all postmenopausal women, so 65 years and older, or if they have one risk factor for osteoporosis, or if they have sustained fragility fractures. DEXA scan in postmenopausal women if they're 65 or older, okay, if they have a risk factor and they're postmenopausal, if you want to do it, or if they have sustained a fragility fracture for one. For perimenopausal patients, if they have a risk factor, or if they have very, very thin, so low BMI, or if they're on any medications that are known to accelerate. So not everybody that's perimenopausal yet, but for postmenopausal, the majority of those patients, especially if they're out over the age of 65. This chart will define your osteopenia versus osteoporosis using that DEXA T-score. Our normal bone density is going to be between -1 and +3. That's what we like our patients to be. If they're between -1 and -2.5, okay, we're going to consider that an osteopenia. Osteopenia, so we have thinning of those bones, and those patients need to have treatment to help prevent that osteoporosis. Less than -2.5 is considered that osteoporosis. And so, and then if they have a T-score of less than -2.5 and they have a history of fractures, that's considered severe osteoporosis. Meaning we're a little bit late to the game in the management of these patients. Doesn't mean they don't get treated. We certainly want to do that, but we'd like to catch them before they have osteoporosis or severe osteoporosis. Again, diagnosis, if they have a fragility fracture, so hip, spine, wrist, or if that T-score that is less than or equal to -2.5. We use that by doing our DEXA scan. That's how we get our results. So it's important. I think you guys, majority of you guys will be ordering these DEXA scans. You need to know when to order them, who to order them on, how to order them for these patients. There's unfortunately no real clinical manifestations until someone fractures something, right? So they can't say like, oh, my elbows hurt, my knees hurt, I think I have osteoporosis. That's not osteoporosis, right? They can't say like my long bones hurt, I think I have osteoporosis. We have to be able to assess their risk factors and assess their age for us to help determine the likelihood of having osteopenia or osteoporosis. So ideally, we want to prevent this. And we can do that by doing regular weight-bearing exercises. They can walk, they can do some elliptical, they can do a little bit of dancing, and also adding some lifting weights in there tends to help as well. Talk to them about decreasing their fall rates. So some of these older patients, especially that have a history of falls, there's actually people that will go out to their house and assess their home to make sure their home is safe for them so they decrease falls. You want to tell them, pull up the throw rugs. You don't want to have that. Have your furniture spaced apart so that if you are walking, you do become a little lightheaded and you're off balance, you can go from one piece of furniture to the next piece of furniture, which will reduce the fall risk. Again, bone mass density testing in those patients at appropriate age or having risk factors. And then the recommendation is for our patients or us to measure our patients' height annually. If we start having a significant decrease in height, which we often do, but if that happens over a 6 or 12 month period and they've lost an inch or two, that may be an indication that they had a vertebral fracture that was undiagnosed. So measure that height annually. Talk to your patient about calcium and vitamin D supplementation. Patients over the age of 51 should really have about 1,200 milligrams of calcium a day. And that's not easy to take because calcium, you're supposed to take it with orange juice in the morning, and so some patients just don't take it as quickly. For postmenopausal patients that have, they don't have any fractures or fall risk, we talk about vitamin D at 600 milligrams a day. If they have higher risk or over the age of 70, we go 800 vitamin D. So calcium and vitamin D supplementation, we want to talk to patients about that. The primary goal really of osteoporosis is to prevent it, and then if we need to, though, we need to treat it. So now start therapy when they have evidence of osteopenia or osteoporosis, and that T-score is less than 2.5, or if they've had some sort of fragility fracture. Or if it's between -1 and -2.5 and they have risk factors, we want to put these patients on medication. There's some medications that we can use. We already talked about estrogen, and that helps increase bone mass. That will help prevent for these patients on a hormone replacement therapy. The SERMs also help. Azoxystrobin is good for that. Bisphosphonates is one of the common medications that we use to treat and prevent. We've got calcitonin, we've got vitamin D. So we want to talk about putting these patients on these medications to help prevent and also ultimately help treat. They've been biphosphonates and now the SERMs as well are one of the primary treatments that we have for osteoporosis. And they work by inhibiting the decreasing of reabsorption and helping with bone development. Unfortunately, with the biphosphonates, especially people that have GI issues already. There's decreased GI absorption. So we do recommend patients take it on an empty stomach and remain upright for at least 30 minutes after taking the medications. There are some very, very rare side effects associated with the biphosphonates. So patients can have osteoporosis of the jaw, they can have atypical femur fractures, and usually this is in patients that are taking the medication longer than 5 years. So the recommendation for these patients is that they do a drug holiday. If they have to be on the medications for greater than 5 years, then the recommendation is to take them off for at least a year, and then do a reassessment, and if needed, then they can go back on. So I don't recommend using greater than 5 years without some sort of holiday. So the best thing for management is prevention. So we want to talk about biphosphonates, but we'll prevent and treat the osteoporosis. Vitamin D and calcium supplementation will be a part of the prevention and ultimately the treatment as well. Again, we want to think about, especially with calcium, patients that have a history of kidney stones, this may increase their kidney stones, so you've got to talk about that risk that's associated with that. That's it for our menopause and osteoporosis. Let's go into our vulvar and vaginal. And this is so funny. I love it so much. How do you hide how much vaginal? Carefully, because it's fragile. It's so good. We were driving somewhere. I think we were driving to the beach. And so first of all, I'm driving to the beach, doing a vaginal vulvar election at night in the car. You should have seen the truckers beside me. They could not. They were just like, they would go try to drive out, and they'd be like, Yeah, I mean, they would just be like right beside us for miles and miles and miles. And the thing is, I had to put it that way because I got kids in the back seat. So I can't have them be like, Mom, what are you doing? And I'm like, oh, so I put it this way, and the trucker's like, hey. Like, no. But anyway, I found this driving to the beach, and I was like, oh, this is perfect. All right, so here are TLOs and ELOs. All right, lab value that indicates menopause. Elevated progesterone, no, because that's going to be decreased. Estrogen, no. Not decreased FSH, but elevated FSH, yes. Oh, actually, doesn't really postmenopausal patient, 59 years old. She's having vaginal dryness, intermittent dysuria, severe hot flashes that occur day and night. Sounds familiar. No smoking. She smokes though, and she drinks, and she's having a good night. Past menopause with hypertension and prediabetes. Oh my goodness. She needs some counseling. Hormone therapy is suggested as a primary treatment of what disorder? After all of that, this is all I want to know. Vasomotor symptoms. Yes, vasomotor. She needs it for a lot of other things, but it's primarily for vasomotor. All right. So vaginal tissue. And vaginal tissue is the vagina is medial to the heart line, so it's made up of this non-keratinoid stratified squamous epithelial tissue, which means it's more sensitive. Okay? It's more friable. It's very estrogen responsive, and it produces a substance called glycogen. Glycogen is then metabolized to lactic acid. And lactic acid is really important because it protects the vagina. It helps keep the vagina more acidic in nature. And then ultimately the goal is help keep bacteria and other bugs out of the vagina and out of the uterus and bladder. So what this does is it also helps keep the vagina in an acidic environment. So usually the pH for the vagina, the normal pH is around 4 to 4.5. So if you have less than that or more than that, that's kind of an indication that we have lost the homeostatic balance of the vagina. So something is affecting that glycogen production, something is affecting that transition to lactic acid. There's a lot of different aerobes and anaerobes that make up the vaginal flora, but the predominant one is going to be this lactobacillus. It's a picture here of some lactobacillus. They produce that lactic acid, which again keeps things out, helps prevent these patients from STI and vaginal infection. When we change that vaginal flora, we change the ecology, then we increase the risk for patients getting these infections. So anytime we change that makeup, that microflora, we increase the risk of infections, STIs, bacterial vaginosis, or vaginitis. That can be done by antibiotics. Antibiotics are known to change the vaginal flora. You will have patients that come in and say, and you tell them, we're going to give you antibiotics, and they will ask you to give them something for a yeast infection because they always get a yeast infection when they take antibiotics. Just give them something for a yeast infection. Don't argue with them about it, just give them something. Usually you can give them something like a fluconazole, and it works pretty well. There's no reason to test them to make sure they're telling the truth. Most people aren't going to tell you that they have yeast infection unless they have it. So I would just give them. Douching on a routine basis. So many years ago, douching was the in thing to do. Now it's not the in thing to do at all, and it actually changes the makeup of the vaginal flora. Sperm, actually semen, change the makeup of the vaginal flora as well. So anytime somebody has unprotected intercourse, it's going to change that microflora, increase their risk of STI. Tampons or diaphragms can change the vaginal flora. And then when someone's on the menstrual cycle, we know we have a change in our hormone levels, and that's going to change our vaginal flora. Pregnancy does that as well. Menopause, we just talked about, hypoestrogenic state causes atrophy and causes change in that vaginal flora. And then anybody that's on hormonal contraceptives, they may also have an increased risk of something like vaginal candidiasis or yeast infections because of the hormonal contraceptives. You want to think about that in these patients that are coming in, especially those that come in with repeat infections, trying to figure out if they have a causative agent. When there's something that offsets that vaginal flora, the vagina then is no longer going to have that protection from infection or from inflammation. The most common issues that we see is something called vaginitis. And vaginitis simply means vaginal inflammation or vaginal infection. The three most common things that cause vaginitis are going to be bacterial vaginosis, which is the most common, vulvovaginal candidiasis, and then we have trichomonas. The first picture here, I don't know if you remember, did you guys get to do any lab stuff? We used to have to go to lab as the PA and then a microscope there, and you take your vaginal swab, you put it on a little, what's that called? Slide. Yeah, see, words, not my fault, Menopause. Put it on a slide, and then you have to look at it yourself. The lab says it's not going to approve it, so we can't look at it on the slide. That slide's underneath the thing. You have to look at it, so we have to put all these out. So that first picture, anybody know what that is? Clue cell, yes, very good, the clue cell. And then the other one, hyphae, so the hyphae, and the last one then would be, and how do you know? It's got a tail. It's got a tail on there. Those are always fun to see, and then you tell your patients, I see what that is. Bacterial vaginosis comes from the Gardnerella bacteria. It's the most common cause of vaginal discharge in infancy. Until around 2015, this was considered a sexually transmitted infection, meaning you treated the patient and the partner. That's not the case anymore. Women can get bacterial vaginosis outside of intercourse. Okay. Most commonly, these patients are going to come in presenting with this homogeneous, kind of grayish discharge. Oftentimes, a patient will say it has an odor to it, or a fishy type odor to it. And this results really because of the reduction of that lactobacilli. We no longer have that protection. We no longer have that acidic environment because of these multiple organs that are being affected. So we have a shift in that vaginal flora. Risk factors, yes, even though this is not specifically transmitted via sex, if they're having multiple sexual partners, that's going to change the makeup of the vaginal flora, and that's going to increase the risk of the bacterial vaginosis. Female partners are more apt to get bacterial vaginosis than male partners. Even if it's in a female-female relationship, it still increases the risk of bacterial vaginosis. Oral sex practices, the saliva in the mouth, can affect the changes in the normal flora of the vagina. We always talk about douching. African Americans are at higher risk because they do often douche more, and then just the change the hair components as well. Smoking, IUD, and that's why before we place IUDs, we want to make sure the patient doesn't have a bacterial infection or vaginal infection before we put that in. Reduced risk is condoms. Condoms can reduce because we're not changing the vaginal flora. Okay. How do we diagnose it? So nowadays, most of you guys will have what they call a vaginitis panel. Okay. For some of you that have not been transitioned to NHS Genesis, when you go out in phase 2 and beyond, it may be called the KOH or wet prep panel. So either one of those. So you take a swab of the vaginal secretions and you send that off to lab, and lab very nicely in a couple of hours sends you a little note that says, here's what your results are. So you don't have to look at it underneath the microscope. If for some reason you don't have a lab, or you're seeing patients who can't send this to lab, or it's a send out, you can't get it back, you can use some clinical criteria. They're called the AMCEL criteria. You get 3 of the following 4. So, grade discharge, looking at pH, a whiff test, and then clue cells on a wet prep. So that means you need to have a microscope, and you take a little swab of vaginal discharge, and you put it on there, and then you go look at it under the microscope. So how do we check for the pH with pH paper? Okay, so usually we'll do it for the vaginal flora. We'll do it for, if we're looking for if somebody's pregnant and we want to know if the fluid that they're having in the vagina is from the rupture of the amniotic sac. We can use it. We can use it if they have eye issues. We use this pH paper. If that pH paper turns blue, that means your pH is greater than 4.5, and that is one of the AMCEL criteria. So that would be the first thing you can do for the clinical if you don't have lab. The next fun or not so fun thing is the whiff test. And literally that is what we used to have to do. So you take the vaginal secretions, you put it on the slide, and you take KOH, which is potassium hydroxide. Potassium hydroxide, you put a little drop of potassium hydroxide in the oil, and you sniff, and the amides react with the Gardnerella, and it creates this fishy odor that comes off of when you do the potassium hydroxide. Not normal saline, but specifically potassium hydroxide, the amides will do that. Right? And so you can smell it. If you smell fishy, then that is your clue. Okay? So I would say thank God for technology, right? Because nobody likes to do that, I promise you. So that's how ultimately we can do the diagnosis. Really, for the majority of you guys, you'll probably just be sending it to the lab. If on physical exam you see that gray discharge, I don't think that most people are going to fault you for not doing the whiff test. You can certainly check the pH, but if you have suspicion, you can treat these patients. If you don't treat them, we have consequences that can occur. We have increased risk because we're changing the vaginal flora. We have increase for other things, like gonorrhea, like chlamydia, like even HIV or simplex virus. Okay, there's increased risk that bacteria is going to go not only just in the vagina, but into the cervix, and then out to the fallopian tubes, and increased risk for tubal ovarian abscesses. Okay, can cause persistent HPV infection. Younger folks typically have HPV. It's going to go away because the body's ability to fight that. These patients are increased risk for HPV infection, which ultimately increases your risk of what? Cervical cancer. You have HPV that's prolonged, increase your risk of cervical cancer. Increased risk of endometritis, which is the endometrium, is going to get infected. These patients will be super sick with that. If someone had a hysterectomy and this was not diagnosed, they can get super sick and have bad infection after the hysterectomy just from the bacterial vaginitis. And then, of course, if they had some sort of miscarriage or abortion and they're trying to do instrumentation through infection, then that's going to increase their risk of post-infection or sepsis. Okay. Pregnancy, bacterial vaginosis for pregnancy is a big deal. Associated with premature rupture. Remember, in preterm delivery sometimes, intra-amniotic infection, so that, again, the bacterial vaginitis can go up through the os and then get around into the amniotic sac. again, postpartum endometritis as well. So patients that are pregnant and they come in, if they have signs and symptoms of bacterial vaginosis or they're having discharge, we're going to swab that discharge and send that out. If that's positive, these patients need to be treated. This is not a wait and see, this is a definite treat. We've got a couple different options for pregnant patients. Metronidazole is still going to be your primary treatment. Again, if you're reading literature that's several years old, it'll say in there metronidazole is contraindicated in the first trimester. That is not the case anymore, which is why I have that question mark there. The reading literature does say that, but nowadays they said no, it's okay in the first trimester. You can do it twice a day, or you can do it 3 times a day. Clindamycin can be treated, Metrogel, which is an intravaginal treatment, can be done, or clindamycin intravaginal can be done as well, if they're allergic to Metro. The Metro is typically going to get one of the primary. Okay. What we often do in pregnant patients is in that first evaluation, we check them for this. We check them for VB, we check them for gonorrhea, we check them for chlamydia. In high-risk patients, they're going to repeat that. Or patients that are coming with abnormal discharges concerning, and they're going to repeat that because of the complications that we see associated with pregnancy. Okay. In non-pregnant patients, guess what? The treatment is the same. Okay. So you don't have to lot to memorize here. Metronidazole is typically what you're going to use for treatment, and that's twice a day for 7 days. You can do Metrogel, or we can do clindamycin gel as well. You can use clindamycin orally. But we typically use metronidazole for this. Problem with metronidazole, you got to talk to your patients about is they can't drink alcohol. If they drink alcohol with it, it can make them really sick and make them have a really bad metallic taste in their mouth. Otherwise, it's decently tolerable. Reoccurrence is common. Okay? About 50% of patients are going to come back to see you within 12 months saying, look, I was treated, seemed to get better, but now my symptoms are back again. It is possible that they got reinfected, so you want to get a good history, a good sexual history on them. A lot of times it's really failure to eliminate the initial problem, the initial infection. Unfortunately, treating the male partner does not seem to be a benefit. So first of all, you want to consider expanding your differential. Is this only bacterial vaginitis? So in other words, did you only send a vaginosis vaginitis panel? I don't do that. If I'm going to send vaginal swabs, I'm going to send it for all of them from the beginning because I just think it's good practice, but that's going to be what you decide to do in your practice. So nowadays, we do have the capability to have the patient go in and do self-swabs, and a lot of literature on that. So they'll go to the bathroom, they'll take a swab, and they'll put it intravaginally, and they'll bring it back to you. So I just have them take 2 swabs, and one will be gonorrhea chlamydia, and the other one will be for vaginitis. But if you didn't do that, then expand your differential. Vaginitis panel is really nice because it not only talks about bacterial vaginosis, it also talks to you about, tell you if they have yeast candidiasis. So expand your differential. Talk to your patients about probiotics as well. So probiotics tends to be good for that reoccurrence, not necessarily good for the initial treatment for your bacterial vaginosis. And then ultimately, it may just be that I'm going to try to help your symptoms, but you may be a carrier of this Gardnerella species, and I can't necessarily eliminate it, but when your symptoms get really bad and really bothersome, come back in and we'll put you on antibiotics, antibiotic treatment for that week or so. If they've had more than 3 episodes of confirmed bacterial vaginosis in 12 months, meaning I swabbed them 3 times, every single time it's positive, and they have not used intravaginal clindamycin cream in the last 12 months, you can try it. You can try the clindamycin, which completely change our medication. Or you could put them on either the Metro regimen or the boric acid regimen. So the Metro regimen, you're still going to give them metronidazole 500 twice a day for 7 days. Then they're going to do intravaginal Metro cream or Metro gel for 4 to 6 months. We're going to try to eradicate the species. We can do boric acid, which we're still going to Metro 500 twice a day for a week. That's going to be our initial treatment. Okay, we're going to then add, at the same time, they're going to do that intravaginal boric acid, okay, at bedtime for 30 days. Then Metro for another 4 to 6 Metro intravaginal cream or gel for 4 to 6 months. Okay, so we're still going to give oral We're gonna add boric acid. That boric acid will be from the very beginning all the way to 30 days. And then after that 30 days, we're gonna do the metro dose. So those are the two. If they have reoccurring, we're trying to just eliminate and get rid of that Vaginal, which is in the vagina. All right, the second most common cause of vaginitis is going to be candidiasis, vulvovaginal candidiasis or yeast infection. The majority of yeast infections are going to be caused by Candida albicans. Okay? Usually the rest of them is Candida albicans, but there's about 10 different Candida species that it could be. All right, so for some of these, you got to keep that in mind when patients come back with reoccurring Candida infection. These patients oftentimes will present with vaginal itching or burning or irritation. They may have post-void dysuria or urticaria after IP, and their discharge is typically a thick, whitish cottage cheese type discharge. It usually does not have an odor that's associated with this. Risk factors, right? Oftentimes during their menstrual cycle, when we have higher levels of estrogen in that later part of the follicular phase, these patients may have increased risk, so increase in estrogen levels. Oral contraceptives, especially if they're estrogen, have higher amount of estrogen that's in there. Pregnancy, because that is a high estrogenic state. If they're immunosuppressed, things like diabetes, chronic steroid use, chronic endocrine diseases, they can have increased risk of candidiasis as well. And then we already talked about antibiotic use. And those patients that complain of, say if they have infections or antibiotic use, we'll just go ahead and treat them. For laboratory, we still have a vaginosis vaginitis panel. Okay? They're going to be looking for yeast on that, or when they do the vaginosis vaginitis panel, it's a machine that looks for all of that. Again, for some patients or some people, depending on work, might be a KOH wet rep. And then clinically on exam, we can look for that thick white discharge. pH for this less than 4.5. So thick white discharge less than 4.5, before is greater than 4.5. And then erythema, you might see some excoriations. Unlike atrophic vaginitis, where the vaginal tissue looks pale, this is erythematous vaginal tissue. And sometimes you'll see discharge coming really from, you'll see discharge at the part of the external vagina. And sometimes if you do a vaginal exam on these patients, you'll see thick discharge in the vaginal wall itself. How do we treat these patients? It's uncomplicated. We can do intravaginal clotrimazole or miconazole or ticonazole. And those are all over the counter, and we have them in the military system as well. Intravaginal tericonazole can be given, but that requires a prescription, typically 3 to 7 days. A single dose of fluconazole is an option as well. If they're pregnant, then we typically will stick with intravaginal miconazole, and that would be done for a week. These are just the different conazoles or azoles that we can use. And again, tericonazole is our prescription, the rest of them are over the counter. So why would someone choose topical versus a one-dose oral? So oral azoles, they do increase liver enzymes. So if someone has chronic liver disease, probably not a good choice to give them an oral azole. And maybe they're on medications that have interactions with the oral azoles. But the clinical improvement or the patient's improvement of signs and symptoms, there doesn't seem to be a little bit better response for our PO meds, earlier symptomatic relief in our PO meds, or with our topical medications in our PO meds. So PO is preferred in the majority of patients because it's one dose. Again, you gotta tell them the intravaginal is usually for 5 to 7 days. You might get symptoms improve a little bit earlier, but if you just take this one dose, the symptoms are still going to improve in a couple of days. Similar clinical response overall, so not earlier response, but overall, their symptoms are still going to improve whether they do the oral medications versus the intravaginal medications. It's just about what most patients will choose to have the oral pill. If they have recurrent infections, so 3 or more episodes within a year, happens in about 5% of patients. Oftentimes it's a host issue. oftentimes it's something that they're doing. You know, again, how well controlled is their diabetes? Are they on oral contraceptives? Maybe that needs to change if they're already doing. Are they using a diaphragm for contraception? Are they frequently on antibiotics? Are they wearing tight-fitting clothing? So a lot of people nowadays wear the Lululemons, right? I want Lululemons so bad. They're so expensive. Like I can't even justify the cost. But they're cute, right? So people walking around them all day long. They've been to the gym for 2 hours, they're walking around. Well, that is going to increase. You want to talk to your patients about, let's talk about your, not necessarily personal hygiene habits, but let's talk about, do you feel like you wear tight fitting clothing a little bit more often? And how often after you work out you change your clothes and that kind of stuff. So we've got to figure out the problem, because usually there is a problem. Sometimes there isn't, and sometimes it's one of those others. It's not Candida albicans, it's one of those other species. So maybe Candida glabrata. And Candida glabrata is resistant to our normal azole treatment. So it's resistant to the diflucan or fluconazole, or be resistant to the intravaginal cream. So sometimes if that's the case, we may actually have to send a vaginal swab out for a culture specifically to identify what type of candidiasis is, or what type of candidiasis is this? Is it albicans, or is one of those more rare times too? So we can further define what our treatment can be. So if they have reoccurrent, it's an acute issue, and we can do local intravaginal therapy for 7 to 14 days, or fluconazole, 1 pill every 72 hours for 3 doses. Okay, so days 1, day 4, and day 7. Okay, for suppressive treatment, once we do the acute phase, we're going to do suppressive. We're going to come back on oral fluconazole, 150 milligrams once weekly for 6 months. And what does that mean? That you need to monitor liver functions. You need to monitor liver functions with that. So once a month, you're going to have them come in and get their labs run, make sure liver function goes right. They may need to continue indefinitely, depends on if their symptoms reoccur once you stop at 6 months of treatment. If it's a non-albicans species, again, more resistant to the azole treatment, then we talk about things like boric acid, and we do have boric acid intravaginal tablets in the military system. Okay? Up to about 70% cure by just switching over to boric acid treatment. Again, fluconazole we can use, but a lot less responsive to the azoles. And then there's something called it's a topical fluticasone, right? And that is to help with the irritation, and they can use that at night for about a couple of weeks. For symptomatic treatment, external, we can use something called lotrazone. So lotrazone is a combination clotrimazole plus betamethasone, so has a little steroid in there. So if they have a lot of external itching, a lot of external erythema, you can prescribe this topical medication, which will help that, in addition to the other medications. So this is not in place of, it's in addition, and that will help with the topical symptom, or the intravaginal itching and irritation that they're having. I also think this is fun, especially in flu season. You see me pretty scared of catching the flu, someone's not remotely scared. I need to come in, I think I have the flu, but when I come in, we're discharged. It's like, how long got it? Oh, I don't know, I think 2 or 3 weeks. But if you have the flu, you come in immediately, because you need what? Quarters. You need quarters. I know it already. The third most common cause of vaginitis is going to be trichomoniasis. Okay? That's the little one with the little tail on it. Okay? This is considered a sexually transmitted infection. The other 2 are not. This is considered a sexually transmitted infection. And on exam, these patients have this. This is very unique, very unique. It does look very frothy. Doesn't I don't know that it always looks greenish yellow. It may look more milky white sometimes, but look at it, it's very frothy. It has like bubbles in it. Right? But we think about it as this greenish yellow, frothy discharge, and the odor is this musty odor. Once you smell BV, and once you smell trick, it's something you always remember. It's kind of like the GI bleed pooper, right? Once you smell it, when you walk in the emergency department, you're like, oh, someone's got a GI bleed, oh my God. You can smell it immediately. This is the same kind of thing, right? And so these patients may come in with the discharge, but they may also say, I'm just having painful intercourse, and I know I don't normally have painful intercourse, may have dysuria that's associated with this. And about 50% of these patients have no symptoms. Right? They may come in with lower abdominal pain and not even say they're having discharge at all. And then you do your exam or you do your swab, you're like, oh, this is why you're having all of these symptoms. So it needs to be either differential for someone who has lower abdominal pain or vaginal discharge. Laboratory is going to be that vaginosis, vaginitis panel, or KAH wet prep. They can see down there as well, depending on what your lab is doing. Clinically, we're looking for that frothy discharge. We're looking for something called it's a strawberry cervix. We have a lot of food things that are related in the bowel or vaginosis stuff, right? Frothy discharge, strawberry cervix. So on the cervix, you're going to see little, looks like petechiae, little red dots on the cervix. And that is considered a strawberry cervix. It's almost pathognomonic for trichomoniasis. pH is elevated, greater than 4.5 on our pH, so we refer to our pH paper. Treatment, Metro. So we have single use and multi-day metronidazole. Studies do show that there's a higher cure rate for the multi-day, especially in females, and so I typically will recommend a multi-day treatment. If you have somebody that's not likely to be compliant with a multi-day treatment, or for the male partner, because this is the STI, you can do the 2 grams of Metro. That's really rough on the belly. A lot of people throw up after that, just like when we give them Zithromax for chlamydia, they throw up afterwards. So sometimes you want to pre-medicate them with Zofran, and then they can take that. But ideally, we can do the 7 days unless we want people to take medication. We also have Tindamax, okay, which is 2 grams. That's 1 dose. If they're allergic to azoles, that's the problem, because trichomoniasis only has good response to azoles. And so that's crazy, right? They have to do desensitization treatment so they can actually treat the trichomoniasis, right? We do want to treat the sexual partner concurrently, okay? Because this is, no, I said an STI. This is an STI. And then retest after treatment. So typically females only. And we don't want, yes?
For the allergy and at that point, I know allergy clinics, they do the penicillin challenges that you talk out for. Would you refer them to the allergy clinic for that, or?
So the option is either allergy or infectious disease. Those will be your 2 people. So sometimes what will happen is we will refer them to infectious disease, and they will help us run down, is this truly an allergy? And then if they need desensitization, then they refer them to allergy. So you could do either one, but sometimes it's really about, the patient says they're allergic, but we don't really have any real concise, say, yeah, for sure you're allergic. So we, in the emergency department, because we don't call allergy very often, we'll actually call it infectious disease from the emergency department, and we'll say, hey, this is what we have, or, is this something that you guys can see in the clinic? And for us anyway, they do pretty good with that. They'll see it, that's kind of weed it out. So we do want to treat sexual partners concurrently, and then we're going to retest after treatment. Not before 3 weeks. Even if they come in and say, I'm still having discharge, you want to wait because you can have a false positive. So typically we wait for that 3 weeks to 3 months for retesting. Ideally, I typically do it about 3 months. They come back in 3 months, let's retest you. So meaning we're swabbing you again, and we're going to send it off. Of course, if you're having private before that, come in and then we can recheck, but not before that 3 weeks. Because then they'll end up going back on Metro, and they probably don't need to go back on Metro. Okay? Despite Metro treatment, if it's reoccurrent, then we can do the Tindamax at that 2 grams. Usually that's once a day for 7 days. Okay? The recommendation, at least still for now, is that because this is STI, you should really offer these patients, you should really do full STI testing. So gonorrhea, chlamydia, HIV, And RPR is part of full STI testing nowadays, and it has been for the last several years. And the reason is, how many cases of syphilis did we have last year? 2 million increase, syphilis, newly diagnosed. So what's happening is we're treating these patients, we're saying you should follow up with your primary care for additional testing, and they're not following up with the primary care for additional testing. So these people are being undiagnosed with a significant increase in syphilis, and then HIV is also on the list because they're not doing enough of it. So we want to talk about that. Okay, that'll be it for today. Thank you.